Good day. My name is Tannock, and I'm a retired medical oncologist from Princess Margaret Cancer Centre and the University of Toronto. And I'm going to talk to you today about using either lower doses or shorter courses of anti-cancer drugs to try to improve their access, particularly in low and middle income countries, and ask what we need to do to change practice to make that happen. I don't accept payments from pharmaceutical company, and I try to preserve my independence. Now, a major problem is that most phase 1 studies of targeted agents really haven't changed since the days of chemotherapy. For chemotherapy, it was probably appropriate to assume that the higher the dose, the greater the likelihood of effectiveness, and that dose-related acute toxicity was a surrogate for tolerance. So the assumption that the maximum tolerated dose is the optimal dose may have applied to chemotherapy, but it really doesn't apply to many biological agents. What we should be doing is looking at the optimal biological effect. If you exceed the dose of a targeted agent that maximally inhibits its target, all you'll be doing is adding toxicity, off-label toxicity. Now, reducing registered doses and schedules has traditionally required proof of identical outcomes in very large non-inferiority trials, and certainly the pharmaceutical industry, has certainly encouraged that. Now, we've challenged that concept in a couple of papers, one where we've talked about near equivalence, and another where we've tried to attack the tyranny of non-inferiority trials. And I'll try to show you what we mean by that. So the problems of non-inferiority trials are, I think, multiple. First of all, they demand tight statistical boundaries for a single positive outcome. But we're not really interested in a single positive outcome. Sure, we want to make sure that lower doses or reduced schedules of a drug give at least approximately similar outcomes, positive outcomes, such as overall survival or delay to progression. But we're also interested in toxicity, and particularly in lower middle income countries where these agents are often not available because of cost, we're interested in access. So the non-inferiority trials relegates these other outcomes, and yet they're equally important. It often ignores supportive pharmacokinetic and pharmacodynamic data. So if you've already shown that a targeted agent maximally inhibits its target at a lower dose, you should use that information as well as the information you get from the trial. And comparison of outcomes within a non-inferiority trial doesn't actually allow that you'll get a variable result. It's almost you do one superiority trial and then you regard the result of that as absolute, and a hypothetical trial might not even show standard treatment to be non-inferior to itself, which of course is nonsense. We think that differences between superiority and non-inferiority trials is artificial, and it also depends on when a trial is performed. You do an initial trial to show a new treatment is better than a standard of care, and that requires maybe a few hundred patients, but then you need a much larger trial to show non-inferiority of reduced dose, and that makes no sense. So what we propose is to abandon the term non-inferiority trial. We think all randomized trials are simply comparative. The preferred arm should be selected on the basis of survival outcomes, toxicity, tolerance, and cost. And comparison of registered and reduced doses and schedules should take into account all available information. Smaller randomized trials, but also pharmacokinetic and pharmacokinetic data should be taken into account. And interestingly, that is done when we register biosimilars. So many randomized trials have actually shown similar or identical survival for lower doses or lesser schedules, but those regimens have been rejected despite reduced toxicity. And here's a few examples. So here's duration of adjuvant trastuzumab, 1 year versus 6 months, or 3 trials of that. 1 year versus 9 weeks, 2 trials of that. Look at those survival curves. They're superimposable. And these were large trials. Surgery for colon cancer. Is laparoscopic surgery better than open surgery? Well, they're the same. Supportive care in non-small cell lung cancer versus radiation for brain metastases. Or continuous or intermittent androgen deprivation therapy for prostate cancer, or duration of adjuvant FOLFOX or CAPOX for colon cancer, all of them giving survival, or in the case of the colon cancer, relapsed disease-free survival that are essentially identical. So here's looking at two of those very large trials of adjuvant trastuzumab, one with 6 months, one with 9 weeks. Both of them concluded that non-inferiority of the shorter schedule had not been established. But clearly they give the same outcomes, and the advantage of lesser treatment is clearly obvious. It's much cheaper, therefore affordable, more affordable in low and middle income countries. And although trastuzumab is not a very toxic drug, it's less toxic. And in fact, if that short hair trial of Conti et al. Had been done before the HERA trial, which looked at 1 and 2 years, 9 weeks of trastuzumab would currently be our standard, except not a year. And yet everybody, or almost everybody in the Western world, still gives a year of treatment. And then why do few patients in low and middle income countries actually receive immunotherapy? Now, the 2018 Nobel Prize in Physiology and Medicine was given to Jim Allison and Tasuku Honjo for their discoveries in cancer immunotherapy, highly appropriate. And these drugs were developed in part with research funded by public funds. But except for treatment of melanoma, these drugs are not on the WHO essential drugs list because of cost, and they're not available to 80% of the world's population. A simple question, and I think you can all answer that question. Surely this is not an ethical state of affairs. And there's plenty of evidence that we can reduce the dose or schedule of almost any of these agents. Here's some data from nivolumab. This is the PD-1 receptor occupancy, so that's the target, on T cells at 8 weeks after various doses. And you can see at even the lowest dose, which is far less than that registered, there's essentially the same binding. And then this is a large phase 2 trial of 168 patients for renal cell cancer, looking at 3 different doses of nivolumab, 0.3, 2, and 10 milligrams per kilograms every 3 weeks. You can see overall survival curves are not different, nor is response rate or progression-free survival. And yet what happened? The registered dose of nivolumab is 15 times the lowest effective dose in this trial. And if you actually look at the data from pharmacodynamics and pharmacokinetics, and there's new data coming out, you could probably reduce these doses and hence the cost up to somewhere between 85 and 95%. And that would enable you to treat 7 to 21 times as many patients as we do with a single dose. Of course, that's fought tooth and nail by the companies that market these doses, but it is beginning to happen in India, in other low and middle income countries, thereby enabling patients to have access to what are still effective doses of these drugs. A practical trial that might convince governments, oncologists, payers, patients to use low-dose immunotherapy might be a simple trial of, say, patients with lung cancer, a common disease, with a high PD-L1 score, and randomized between the registered dose, in this case pembrolizumab 400 milligrams every 6 weeks, that's equivalent to 200 milligrams every 3 weeks, and 100 milligrams every 6 weeks. Most of the trials are looking at different schedules, which is harder, but in this case you could actually do it double-blind, and that would, I think, be a very good way of doing this type of trial. And the major challenge, of course, is how to pay for the pembrolizumab, especially the full dose, because the company isn't certainly going to pay for it. And what about other drugs? Abiraterone is a very effective drug that's improved survival for many stages of men with prostate cancer. And this was a near equivalence trial. Only 72 men randomized to receive full dose, registered dose abiraterone on an empty stomach versus a quarter dose after food. And there was plenty of data showing that food increases the bioavailability by a factor of about 5 to 7. And not surprisingly, if you look, admittedly at an early endpoint, at change in PSA at 12 weeks, there's no significant difference. There's even a greater trend for a greater fall in PSA in the low-dose arm, and the time to PSA progression is the same in both arms. The blood sees the dose, the tumour sees the dose in the blood, not what you give to somebody in their mouth. And the similar PK, the similar pharmacodynamic effects, and we did actually apply successfully, Len Saltz and I, to NCCN to include low-dose abiraterone with food in their guidelines. In another study with a colleague, Amol Patel, we've also shown that adoption of the lower dose abiraterone in India can lead to a saving of about $180 million a year for that low dose alone. And that is being done now in many lower middle income countries. So there are absolutely many drugs that are given at much higher doses than are needed. And these are a list of some of the drugs where there is strong evidence that you can use lower doses and thereby make them much more affordable and much more available, particularly in low and middle income countries. We do know, of course, that the US FDA has introduced Project Optimus. This is a good thing. The FDA now requires dose optimization studies for new drugs, but it doesn't apply to drugs that are already approved. And one example, sotorasib, which is a KRAS inhibitor for KRAS mutated lung cancer, non-small cell lung cancer, it suggests that dose optimization is not being applied critically. The FDA required Amgen to conduct a dose-finding study of 960 versus a quarter of that dose, 240 milligrams. There are the results. There is no difference in either progression-free survival or overall survival, but a substantial difference in toxicity, not surprisingly, that 240 milligrams is less toxic. But despite this lack of significant difference in outcome, and I think we can see the outcomes are extremely similar, but greater toxicity, the FDA has still gone ahead and allowed Amgen to endorse the use of the higher 960 milligram dose. Our system is broken. That should not happen. So we need trials, pragmatic trials, evaluating less intensive therapy. There is a false requirement for them to be large non-inferiority trials, and I've already addressed that. There's difficulty of funding them. It's not a sexy thing. People like to give their money to new treatments. It's, I think, an inappropriate focus of funders, journal editors, and reviewers on one outcome measure, progression-free or overall survival, with neglect of benefit due to reduced toxicity and cost, and hence greater uptake. And there's great difficulty in stimulating uptake of lesser treatments, even with this strong evidence to support it, as I've already shown in an earlier slide. Pairwise comparisons is an interesting statistical method of comparing lesser treatments with the current standard of care, led by Mark Boyce and Michael DeBacker in a couple of papers here. How is it done? Well, in the pairwise comparison method, each patient in the experimental group is paired with each patient in the control group. A relative score is assigned based on relevant outcomes. So you can compare every patient in one group with every patient in the other by computer methods. The score is +1 if the experimental group is better, -1 if the control group is better, and 0 if the outcomes are judged similar. And then you simply add up the total score, summing over all the pairs. The method requires individual patient information, so it's very good moving forward for future trials evaluating reduced dosage. So, in conclusion, many anti-cancer drugs are used at higher doses and more frequent schedules than are needed to fully inhibit their targets. Pragmatic trials to evaluate dose optimization are important. Near equivalence of positive outcomes, such as overall survival, with reduced toxicity and cost, should be used to decide the optimal dose and schedule. And any questions you'd like to send me, please send me an email to my email address given there.